So good morning, everybody. I'm Pierre-Yves Turgeon, French-Canadian, and I'm now working in Nantes for a fellowship. So it's a pleasure to be with you and opening this session this morning. I have no conflict of interest. So I will speak about imaging in RV failure. And so just a basic anatomy recall. It's a structure that is just behind the sternum, is the most anterior cardiac structure in the thorax, and is as a croissant or N triangular shape that you need to consider because it's a complex geometry. There's three main components of the RV: the inlet, the body, and the outlet. And we need to know that inlet and body generates the majority of RV stroke volume. There's also two layers of muscular fibers, the superficial ones that runs circumferential, and the subendocardial that runs longitudinal. There's also three distinct mechanisms of contraction. The first one is the longitudinal fibers that draws the tricuspid annulus towards the apex. The second one is the circumferential fibers that move the free wall towards the septum. And the last one, but not the least, there's also a traction of the free wall by the LV-RV continuity, and it generates a significant amount of the contraction. So in normal loading condition, with normal preload and afterload, the RV stroke volume depends mainly on longitudinal contraction. In case of abnormal condition, the RV stroke volume depends less on longitudinal, but really more on radial and circumferential contraction. So there's a lot of etiologies. You can separate it in pressure or volume overload or cardiomyopathy. But I prefer to remind it by mechanism, so you can see this great review by Arrigo that explains the place of all those mechanisms. So the first one is the abnormal preload. You need to know that RV is very tolerant to preload, so it has a greater distension capacity than LV. So at the same pressure, there's a lot more volume in the RV than in the LV. And as I said, for RV contractility, up to 40% of the contractile force of the RV depends on the LV contraction. Also, for the afterload, so in pulmonary hypertension, for example, we need to know that RV is very afterload sensitive. So just a slight increase in afterload results in a dramatic decrease of the stroke volume. There's also altered interdependence that leads to LV compression in case of RV volume overload. And you can see on the echo with the flattened septum. And also an important subject of study in the last years is the RV-PA coupling. That is a relationship between the end systolic elastance, so it's an index, almost load independent index of the RV contractility, and the total RV arterial load that is represented by two slopes. And the ratio between those two slopes determine normal coupling versus pathologic uncoupling. So the normal ratio of EES on EA is about over 1.5, and in uncoupling you move the slope to the right, and it results in it represents diminished RV contractility, and it leads to a diminished ratio. So imaging the right ventricle, I will focus on the transthoracic echo, but I cannot not talk about cardiac magnetic resonance because it's still the gold standard for non-invasive assessment of anatomy, function, and tissue characterization. You can also use cardiac CT, but it's a lot of radiation, and it compared to the CMR, it overestimates the volume and RVEF. You can also use nuclear imaging. It has a good diagnostic accuracy for global and regional RV function. But always remember that for right ventricle particularly, you need to repeat those exams. So TTE is the more important because all those imaging, even if advanced, are load dependent. So let's go back to basic TTE. So it's still the imaging modality of choice. There's limitation to know, but you can always use multiple acquisition views. Don't hesitate to be atypical towards the axilla or sternum, and always use multiparametric evaluation. You need to have a good apical fourth chamber to start with the full RV opening, so in the green line. And after that, you can move towards the axilla to have the RV focus apical fourth chamber, or you can move toward the septum to have a modified one. Those are very useful. And in case of pulmonary pathologies, for example, the subcostal view is a very go-to also. You need to be sure that the axis is okay, not too posterior or too anterior. But so if you see coronary sinus, you're too posterior. So we can do all types of measures. I will skip rapidly on that, but you can do linear dimensions, areas, and full RV volumes. The normal values, you can find them in the guidelines. So for the morphology, we can quantify the D shape by the eccentricity index, and we can quantify the dilatation with the RV-LV ratio. So how to evaluate? As I said, it's a multiparametric evaluation. Even if the ESC guidelines recommends CMR as the preferred method, we should start always with the TTE. And we can do a lot of parameters. It takes time, precision, and passion. So the limitation to know is that the substernal position in this is very superficial, so it has a bad resolution. There's a lot of trabeculation. It's easier to evaluate the longitudinal function, but in case of abnormal preload, as I said, you need to evaluate radial and circumferential function, so it's more difficult. And you need to always remember what is the loading condition of your patient. Does he have pulmonary hypertension or TR? So you all know all those parameters, but some evaluate longitudinal and others global function. So I will pass pretty rapidly on this. Just very important, eyeballing is not a good method of evaluation, because in this patient, for example, you can say that it's normal, but if I show this, there's a torrential TR that leads to abnormal afterload condition. So you can use the TAPC, as you all know. I just wanted to stress the proper alignment is very important. So the M mode need to pass by the apex towards the tricuspid lateral annulus. It's reproducible if you do it like this. It's easy to use, but it's angle and load dependent and only evaluate longitudinal function. You can do the S-wave also. It's the same pros and cons as the TAPC. And you can also do a more global evaluation by the fractional area change, and it integrates the radial function in the equation. But it's pretty difficult because all of the trabeculation, and there's a higher inter-reader variability. So I just wanted to stress that it's important to do a RV focus view for the fact, because when you do it like this, there's a very good correlation with the CMR for RVEF and volumes. You can also use the TI index. It's a global evaluation that integrates the systolic and diastolic function. To understand this formula, you have to say that the performant RV has a longer ejection time relative to the old systole. So there's a lot of formula. I prefer the one on the left with the TDI, so the tissue Doppler imaging. It's the best and easiest method because you can do this on a single beat. And on the pulse wave at the right, you need RR interval matching, so it's unreliable in the irregular heartbeat, as I said. So for the RV strain, so you need to integrate it in clinical practice now, because it has a very good values. So you need to do this on RV focus apical views, and the normal are minus 23 to 20%. So it's pretty easy nowadays. I just want to stress that it's vendor independent, so there are normal values that are published, but you need to know with which machine they work. And lastly, I just want to show you some 3D images. The great advantage is that it includes outflow track, and there's a good correlation with CMR, but it's time-consuming despite the artificial intelligence. Maybe it's going to be better in the next years. And you have the abnormality. I will not talk about this because I don't do it in clinical practice. And I think someone will talk about this, but it's very important to evaluate the preload with the inferior vena cava, the hepatic veins. The afterload with pulmonary pressure is very important. With the Vmax, it's not perfect, but you can trace the mean gradient, for example, and even calculate the resistance. So I will skip this part. So in the future, what we have non-invasive pressure loops evaluation, RV myocardial work. We can quantify 3-axis quantification of 3D shortening, and maybe AI-based or machine learning 3D echo software will increase in quality and save us time and do a more complete evaluation. So in conclusion, sorry for the time, you need to be systematic, it's complex, you need to know the strengths and weaknesses of every parameter. Always integrate the preload and afterload condition in your analysis. At least include 2 quantitative parameters and be careful about the visual evaluation. Strain for all, in my opinion, it's not hard to do, and it's even easier in the recent years with the automated calculation. We need to integrate RVPA coupling. And are we ready for 3D RVEF? I don't think so, but let's practice. And if it's going to be easier in the future, we're going to be ready. So thanks for your attention.